Hello nurses, this is Kevin with nursingkamp.com, and these are my scribble notes on nursing in the NCLEX. Today's focus on cardiac lecture number 36, myocarditis and pericarditis, infective tissue problems of heart failure. To pave the way, I can be found on social media, Instagram, Facebook, Pinterest, and nursingkamp.com. It's from my sticky note called Infective Cardiac Tissue Problems, where I'm breaking it apart and taking one concept at a time. All right, let's get into it. In my previous lecture, I talked about location of infection, where endocarditis is very specific to the inside of the heart. And usually on the inside of the heart, the endocardium is from the outside problems, usually like drug use or something like that. But what we're going to talk about now is myocarditis. Myocarditis is a smaller topic, but the interesting thing about myocarditis is it can be viral. And the outcome is that they have CHF symptoms. Because the tissue, so think of like a MI. So the problem is the heart just isn't pumping, decreased cardiac output. And they have CHF symptoms. So what are those CHF symptoms? Like S3 sounds, S4 sounds, CHF, shortness of breath, crackles, edema. They could also have thromboembolisms. Usually thromboembolisms are a result of bacterial myocarditis. So what do? You would do blood cultures to see if it's viral or bacterial. But if they're presented with CHF symptoms and there's a problem and there's no history other than a recent virus or bacterial infection and there's no cardiac history, it's usually myocarditis. Some other things that you might look at for that is with myocarditis, you treat the underlying cause, whatever the underlying cause is. And sometimes these patients, might actually need some strong medications to pump this heart because they get pretty CHF as far as low ejection fraction. So they're going to get an echo to see whether or not, see how much damage is to the heart. And they might get some inotropic medications. Inotropic means forceful, force of contraction. It means it beats the heart for it, increases contractility. Definitely bed rest because these patients are going to be really winded and short of breath, and they're going to be acute. What else? So myocarditis is either viral or bacterial. It is acute. They ultimately resulting in some inotropic medications, more specifically like dobutamine, which I call butamine. And dobutamine is, see my dobutamine lecture, which is a beta 1 agonist. And what that means is that it pumps the heart for cardiac output. 4 to 8. All right, let's get into the next one, pericarditis. Whoa. Pericarditis. All right, well, the pericarditis is pericardium, right? So it's outside the heart. So it's the sac that's outside. So it's this section. So when you're looking at infections, it's paid. Okay. And the infections usually call from pericardiocentesis, cardiocentesis. That's where they stick a needle into the pericardium. And that might be because of patient had a previous MI or a cabbage or something like that. And they've had to enter into it, and they resulted in an infection. Or they had to evaluate what's wrong with this fluid here. And that's a pericardiocentesis. They are draining the fluid. So pericardial drains are a risk for pericarditis too. A, aneurysms, structure, infections, bacterial or fungal for this because of invasive, something happened, or it's just in the plasma, in the fluid, pericardial fluid, sorry. And then drugs, certain medications, drugs chat, CH, anticoagulants, P, like Coumadin, heparin, procainamide, anticoagulants, procainamide, and phenytoin, or Dilantin, CHAP. These are all medications that could cause pericarditis, excuse me. All right, so what does the patient look like? Well, this is a characteristic. You're not going to hear extra heart sounds, but you will hear the characteristic leathering, rubbing sound, or pericarditis, a friction rub. And what happens is that the patient will want to sit in a tripod position, leaning forward. And because they want to because the left side of the heart has all this infection, and so they try to get it off of that, and they feel more comfortable that way. The risk is that the fluid starts to build up in this pericardium, and tamponade starts to happen. So they're definitely at risk for tamponade. And tamponade is the triple Ds. See my cardiac tamponade video for that. Distended neck veins, distant heart sounds, and decreased blood pressure. And unequal pulses too, with that. Pulsus paradoxus with tamponade. That's a risk with pericarditis, is that this happens and it actually causes pressure on his heart and they don't pump out as much. Some other things that you start to hear is Dressler syndrome after pericarditis, which is fear. You fear Dressler syndrome. And what that is that fever, effusions. The fluid starts to go into the heart and they start to fuse out. So you get fluid outside the heart. So you get these pericardial effusions. And then acute MI, they can get an MI and they get this rub. So you fear pericarditis. Next thing is, what do we do for treatment? Well, we treat the underlying cause. One, we'll drain them. So pericardiocentesis, we're going to try to take some of this fluid out. We're also going to give them antibiotics, treat the underlying cause. They might get a drain. And that drain, you're going to monitor for kinks and clots. Because if a kink happens here, the fluid can't get out. So pericarditis, the next thing you know, cardiac tamponade. So it becomes a further problem. So you always monitor pericardial drains for kinks and clots. And for anything greater than 100 cc's is always acute out. Steroids for inflammation. So they're all going to be inflamed. So you're going to want to give them steroids. You'll monitor glucose because of steroids and white count because of steroids. Also, monitor ST changes for MI, okay, or ST depressions. So pericarditis, pretty acute. It's usually invasive. It's something caused it to happen. We monitor for cardiac tamponade. A lot of other specific things like distended neck veins, distended heart sounds. It's very specific. They sit forward, so it's a very characteristic thing. You'll listen to the heart sounds with them leaning forward like that. And you're going to be listening for that friction rub. So there's a distinct difference between infective tissue problems On the NCLEX, though, when they talk about it, it's not so much why that happened. It's more about what they look like or the anticipating findings. So whenever you're taking care of a patient who's a post-CABG or a patient has a recent history of an infection and you start to hear new and distinct heart sounds, it's usually leaning towards something infective, and it is acute. There's nothing we can do about that right now. We can give some medications, but we have to treat the underlying cause. Well, that's about it. My name is KAMP, and this is Nursing Camp, and these are my sticky notes and cardiac lecture. That's it. Follow me on social media. Nurse on.